We're here to talk about the importance of smoking and mental illness. I wonder if perhaps, Dr. Mitchell, you could start by telling us about the importance of smoking in the general population.
Well, let's look at the big picture. In the general population worldwide, there are about 1 billion smokers. And although the rates have been improving in high-income countries, in low-income countries, rates have been deteriorating. You know, there's a big promotion from the cigarette companies in the developing world, and that's a serious concern right now. Now, of smokers, about 50%, it's estimated, will die of a smoking-related ill health problem. They'll basically die of a smoking-related disease, and that could be a cancer like lung cancer, a lung disease like COPD, or a cardiovascular condition like a heart attack. So overall, we actually know that from a very interesting report from the WHO, that's World Health Organization, in 2009, called Global Health Risks, that from 2009 onwards, smoking has now been ranked in high-income countries as the #1 cause of mortality and the #1 cause of disability. It's ranked as #1 in both big domains. Mortality means premature death, and disability means problems with day-to-day function. You know, you're not able to live your life to the full. In terms of disability, it's accounting for an estimated 11% of worldwide disability, and that's the equivalent to alcohol problems and obesity combined in terms of the effect on disability. And in terms of mortality, the WHO estimates that smoking accounts for 18% of all deaths worldwide, and that's higher than diabetes and high glucose levels, and it's higher than hypertension, which is a known risk factor for many diseases like stroke and cardiovascular disease. So from a population point of view, we know that smoking is a major concern, and although there are some improvements, there are certain populations and certain areas where smoking is still at the same rate it was 10 or 20 years ago.
What is the trend in the general population in smoking versus the population of those with a mental illness?
Okay, so in the general population, like I say, the trend is improving overall. So let's look at the US and UK. So for the US and the UK, the rates were at their peak in the 1950s, 60s and 70s. In that time period, 60% of males and 30% of females were smokers, current smokers, a huge rate for the general population. Then from the late 70s, early 80s till now, the trend has been basically improving, such that from 2012 onwards, for the first time, we can say that in the US and UK, there are less than 1 in 5 of the general population who classify themselves as current smokers. In fact, there are more ex-smokers in the general population than there are current smokers. 20% current smokers, 25% ex-smokers, which shows you that a lot of people recently have been given up smoking and classified themselves on surveys as past smokers. What about the trends in mental health? Well, we have actually been able to look at this. For example, Health Survey England conducted a survey of 8,000 randomly selected patients, of whom a proportion had a mental ill health concern. And they showed that same downward trend for the general population in those that had no mental health concern. But in those with a mental health concern, rates continued to be high. And not just high, they were about twice that of the general population. So to put that into black and white figures, in the general population, the rate of smoking was 20%. But in the group with common mental health problems, for example, depression, anxiety, then the rate of smoking was 40%, and maintaining a level of 40% over the last 20 years with no substantial gain over the last 5 or 10 years, which is really worrying, given that we've had a lot of national incentives to stop smoking, like smoke-free environments, smoke-free restaurants, smoke-free pubs, smoke-free hospitals. All that's come in, particularly since 2007, into law. So to not really see a shift in those with a mental health concern is a major worry.
So Is smoking actually a risk factor for mental illness?
Yes, it does seem to be a risk factor for mental illness, but it's a hard risk factor to quantify. So one type of risk factor would just be a risk factor on that day. So for example, if you interviewed people with depression, how many are going to be current smokers? That really is just the rate of the two things co-occurring, the comorbidity rate. But by risk factor, we often mean does one factor, like smoking, actually cause, or is it associated with a later development of the key physical or mental concern? So to put that in black and white terms, there's a very nice summary of this data which has just come out in 2013, a joint report on smoking and mental health from the Royal College of Physicians and the Royal College of Psychiatrists, and that document is free to download. They summarized the risk in each category for smoking and each category of mental health problem. So one of the biggest categories was depression. And we know from that data, from that mathematical summary, that smoking does indeed appear to be a risk factor for later depression. And the risk factor is of the order of 50%, a 50% increase in the proportion who develop depression in smokers compared to non-smokers. And those are over time, over 5 or 10 years in longitudinal studies. Even more than depression, the risk is greater for dementia. So if you're a smoker in early life or midlife, your rate of developing dementia later is approximately 60% or 60% greater in smokers compared to non-smokers. There probably is a risk for schizophrenia and psychosis. It hasn't been mathematically quantified because the data is less consistent in that area, and in addition there are fewer studies in relation to following up patients who may later develop a severe mental ill health concern characterized by schizophrenia. So that bit of data is unclear. In fact, there's a Swedish study which showed either no risk or a very slightly lower risk for smokers. So although that was the odd one out, it does raise a doubt whether smoking is a risk factor for schizophrenia longitudinally. But we know cross-sectionally the rates of smoking in all of those problems are very high. So to take it from the top, those who have illicit drug misuse habits have the highest rate of smoking, about 70 to 80%. Those who have an alcohol use disorder, basically they have an alcohol problem, not surprisingly perhaps, they have a very high rate of smoking of the order of 60 to 70%. A surprise to me, those with bipolar disorder have a very high rate of smoking at any one point in time, subject to interview, and the rate of smoking there is around 60%. And the rate of smoking in depression and anxiety disorders, particularly generalized anxiety disorder, which is a disorder with mixed anxiety symptoms, which the patient feels are out of control and now out of their control for a period of 6 months or more, then the rates are approximately 40%. And finally, I've left out a category which is schizophrenia. The rates in schizophrenia are appreciably high. We thought it was in the order, when we did a recent meta-analysis of this in different types of schizophrenia, 50 to 60%. But there's another study, a meta-analysis from 2005, okay, it's a little bit old, from Diaz and De Leon, which showed up to 70%, at least for males who had schizophrenia, who were smoking. And that sounds like, well, is that an odd one out in the literature? But there's a very big Australian survey called the second Australian Survey of Psychosis, the second wave. The first author on that study is Sherry Galletri et al. And that study of 1,000 patients with schizophrenia who were men and 1,000 women showed really high rates for 2012. 70% in fact in men and 60% smoking rates in women. So all told, in all studies that we really have good data from, the rates of smoking are really very high in mental ill health settings and in mental ill health populations, and we really need to understand why that is. One possible explanation, by the way, comes from our work in subtypes of schizophrenia. And one subtype of special note is first episode psychosis. First episode psychosis is patients who have just developed psychosis or just developed schizophrenia, and they are in their, by definition, first period of illness. Now, the importance of that group is they're a young population who are vulnerable, and that is the group that has been most targeted to look at potential areas of prevention. And what we found when we looked at first episode psychosis, and there's another paper on this as well by David Shears and Helen Lester, who basically found the same thing. Rates of smoking in first episode psychosis are already markedly elevated compared to the general population. Roughly 40% are smokers at that early age with first episode psychosis. That's at least 2 times the general population rate, because in young people the rate is less than 20%. So there's really a marked concern from an early age. And in fact, that David Shears and Helen Lester paper showed that 80% of people who developed schizophrenia started smoking before they actually had schizophrenia. So that's another flag. It's a red flag to ask what's going on for that population. We don't really fully understand why patients with mental ill health smoke to the degree that they do. We don't really have a good handle on that. We know there's been institutional factors and provider factors that haven't helped. For example, if you have been onto psychiatric wards in the last 10 years, there's almost a culture of smoking which is endemic to those wards. And staff have often expressed in surveys reluctance to help patients stop smoking, because they've thought, well, I'm worried that the patient may have an exacerbation of their illness, or I'm worried there might be a behavioural problem, some kind of crisis if the patient stops smoking. However, when those patients have been helped and actually have quit smoking in a mental health setting, and the staff re-interviewed, the staff have often changed their attitude and said, no, it's fine now, I appreciate that we've done a good job. So there is often a fear of helping patients because of that culture of smoking on the wards. And I actually remember as a trainee, when I was working on some long stay wards in Newcastle, actually, we used to use cigarettes as what was called token economy. And what that meant in black and white terms is when you're trying to influence the patient to do something that they were reluctant to do, for example, to eat a healthy diet or take a medication, the staff would use cigarettes as an incentive. They would say, well, if you do X, I'll then give you your cigarette. And if you don't do it, you can't have it. And also, occasionally as a punishment, withholding the cigarette from the patient. So we used to use cigarettes in that kind of way. Now, admittedly, I didn't do that personally because I was only a student at the time, but I certainly saw it, and it was kind of endemic on those wards. So we really did have a culture of acceptance and incorporation of smoking into the general ward environment, which looking at now already looks slightly odd, and in another 20 or 30 years is going to be really an outlier to what were we doing that for. It'll be hard for the general public to understand that. Just the same way that in 20 or 30 years, when the rates of smoking in high income countries are less than, let's say, 10%, it'll be hard for the majority population to understand why people were smoking at all, why we had that culture of smoking in the general population in the 50s, 60s and 70s.
So you've been looking at the giving of smoking advice in those with mental illness. What have you found?
Well, we found that the receipt of smoking advice may be lower in those with schizophrenia or mental health problem than the general population. To put that in black and white terms, smoking related advice is important for the general population. Again, let's look at the big picture here. How many people who are smoking actually manage to quit and become ex-smokers? Well, the rate of smoking in the general population, we summarised at the beginning, about 20% are current smokers. In fact, more people in the general population are ex-smokers than smokers. About 25%, or 1 in 4, are ex-smokers, but 1 in 5 are current smokers. That's actually showing that a lot of people in the population are, over recent years, giving up, and there's becoming a big group of ex-smokers rather than never smokers and current smokers, okay? But in mental ill health, there's a lower proportion who are ex-smokers, which hints that in mental ill health, there is at least a slight difference in degree of difficulty giving up, because fewer with a mental ill health concern actually manage to become ex-smokers. It's a very subtle difference. It's between 5 and 10%. So in the UK, the figures are roughly 25% in the general population are ex-smokers, but only 20% in those with a mental ill health diagnosis are ex-smokers. And in the Galletri study, the Australian one, where 70% of males with schizophrenia were smokers, only 15% were ex-smokers, leaving only 15% who were lifelong non-smokers. And in women, 60% were smokers, 15% were ex-smokers, leaving 25% who were lifelong non-smokers. So there's an importance to look at smoking advice, and we can look at this another way around. What helps a person give up smoking? If the average person in the general population with no help tries to quit, realistically, we know the chance of them achieving abstinence, quitting and staying off smoking is low. And we can actually put that into numerical terms. So what's the percentage of the population who are smokers who successfully give up with no help and no advice? It's around 2 to 4% of the population each year. It's a low percentage. Now that percentage is doubled, at least doubled, if they are curious to go online and look at self-help materials, for example. But of course, we know that population who goes online is probably more motivated to quit. But it's probably doubled again from 2 to 6 or 7% in those who receive simple interventions from a clinician, either their GP or a hospital specialist, or a specialist who deals with quitting smoking, which is a service that's started recently. The Stop Smoking service of the NHS, and other countries have the same thing. So if you receive specific help, your rate of quitting smoking in a year, it's not 50% or 70%, it's still very low, let's be honest. But nevertheless, it may be around 3 times that of the background population ability to quit with no help at all. So receiving some advice is generally helpful. And in fact, some studies have quantified that by the number of hours, by the actual metric of how much time did the clinician give you. And that, believe it or not, has a dose-response relationship between the amount of time given and the degree to which a patient is able to give up. So the amount of time the clinician gives you is quite critical. Now, all said, then, it's important to realize if a certain group in the population are not receiving clinician advice. And what I'm summarizing is from 6 studies that we're looking at in the literature now. We're subjecting this to a data synthesis meta-analysis, i.e. giving the summary statistic from all these 6 studies. We haven't actually got the final take-home data rate yet, but it seems like from those 6 studies, which include Duffy in 2012 and some other brand new studies, 2013, that patients with schizophrenia are receiving less frequent advice to stop. Whereas given these high rates in schizophrenia, wouldn't you expect patients to receive at least equal levels of advice, or maybe superior advice to the general population? So what's going on that means that they receive lower than average advice? We need to look at that. We need to urgently understand why patients are being subjected to that inequality in physician help for some reason that we don't fully understand.
So you're saying that those with mental illnesses are receiving less advice, but is it actually more difficult for those with a mental illness to give up?
Well, I can only say that in the individual studies where they followed patients with time, the rates of discontinuation or quitting in those with a mental ill health concern like depression, which is a more studied group actually than schizophrenia in this regard, their rates of quitting are approximately the same. And in moderate to small studies, there's usually no difference in the quit rates. But if you look at the big population picture, if you look at the ex-smoker rate, then there is that difference that I mentioned between a 5 and 10% difference in those that would self-report themselves as ex-smokers. So I think in all honesty, it is slightly more difficult for somebody with a mental health problem to stop smoking with or without help. But it's not the case that it's impossible to do it. And in both groups, it's difficult. So we might as well, as clinicians, be honest and say, this is going to be difficult for you. What can we do to help you with this? What can we do to improve the quit rates? And what services can we provide? And particularly, what services can we provide for an unwell population who has comorbidity, mental health comorbidity, which is making their life more difficult?
So what should patients actually do who are thinking of quitting?
Well, in broad terms, they should look at their own motivation, the factors that may be driving that desire to give up. I mean, to give you a quick statistic here, the CDC, which is an American organization that looks at disease across the whole population, measured smoking quit rates, I think it was in 2004, and they said 40% of smokers try to give up in any given year for at least one day, but they don't manage it. And 65% have the motivation, have some motivation to give up, but that motivation wavers, when things get difficult. So one thing that can help is looking at the motivational factors, things that can stand to your advantage, things that can help you, things that you can remember in the back of your mind, basically things that may be incentives, let's say, to give up. So whether that's looking at disease variables, disease statistics, this amount of health benefit you'll receive if you give up. For example, half of the negative effect on mortality is clawed back every decade that you manage to stay abstinent from cigarettes, even for a lifelong smoker up to that point. So there's a lot of advantages to health by giving up, and they accrue quite quickly having stopped smoking. It could be benefits to your quality of life. For example, most people ask the question, well, if I have a mental health concern like depression or schizophrenia, maybe I'm going to feel worse if I give up. But the studies actually show that having quit, people feel better for having stopped smoking. So quality of life is usually enhanced by stopping smoking, although it is a difficult time to actually transition from being a smoker to non-smoker. Of course, we acknowledge that. It might be benefits in terms of your finances, in terms of your family, in terms of secondary smoking. There are numerous benefits that might come from quitting smoking. And looking at those factors is quite important at baseline, because that helps you set your goals. The other thing that people can do is set a quit date, a date in which they're actually going to give up smoking. And if they're going to do that, I would advise people to specifically ask for help. And I say that just because we know the success rates are low if people try to give up smoking on their own. I mean, if people have got that motivation and they're able to give up, that's fantastic. But look to your local NHS to see what stop smoking services are available, or if you're in another healthcare provider, look what they're offering, or look online. There's lots of online resources. And actually the online resources can help for trying to quit, and there are additional resources for staying off cigarettes. In fact, some of the literature on self-help shows that the relapse prevention or staying off cigarettes, the self-help resources there are maybe more powerful than the resources that help people quitting in the first place. So that's a useful resource in itself. But getting those sources of help is going to increase your likelihood of staying off cigarettes at least 3 or 4 times. And that includes simple advice and support, or additional specific interventions such as nicotine replacement therapy or medications that actually boost the likelihood of becoming free, i.e. quitting. And the 2 big medications are bupropion, which actually was an antidepressant by invention. It's a dopamine and noradrenaline reuptake inhibitor. And varenicline, which is also known as Champix. And that is a new drug, which is a nicotinic receptor partial agonist, which means it binds onto the receptor that the cigarettes would otherwise bind onto. And it gives, let's call it a partial boost. So it offsets the craving for cigarettes, but it also offsets any side effects of coming off cigarettes, of stopping smoking. And that drug in the trials, there's a trial by the pharmaceutical company who's invented that drug called Pfizer, that's online right now with 500 depressed patients. And their quit rates on that drug were over a year 20%, which sounds modest, but don't forget, with no help at all, we're looking at 2 to 4%. So their quit rates were really quite high on that drug. There is just a couple of cautions with those drugs as an add-in in the mental health domain. And one caution with bupropion is that there may be some contraindications that the physician who prescribes that drug needs to be aware of. And one such contraindication may be a caution with epilepsy, let's say. But that's actually a rare side effect of bupropion, very rare side effect, exacerbation of seizures. For varenicline, then there is a concern, and I have seen it on a patient level, that patients may get a paradoxical agitation and sometimes a provocation of suicidal thoughts with that drug. And there is a new analysis of the association of the prescription of that drug with suicidal thoughts. And there does seem to be a slight signal, i.e. a concern that those in mental health should observe patients where those drugs are prescribed, so that no untoward event happens when we're trying to help people for this very important issue of quitting smoking.
Thank you. I wonder if perhaps you could just summarise your thoughts and your findings on smoking and mental illness for us.
Well, we know smoking is a major population in the general population. If we think what was happening in 1950, 1960 in the general population, approximately 60% of the male population were smokers and 30% of the female population were smokers. Right now, if you have schizophrenia or severe mental illness, the rates of smoking are at least that or possibly worse in some areas, in some countries, which should immediately ring big alarm bells that smoking in our patients who are trying to help, from a multidimensional physical and mental health point of view, smoking is a major concern akin to where we were at in the 1950s with the general population. And I'm sure everyone would say, well, we need to move from where we were in the 50s to now. We've done a great job in moving the general population, from there where the rates were approximately 60% in men to now where they're just about 20%. But we haven't done the same for mental health. Why haven't we done the same for mental health? The actual trends for mental health have stayed flat. In other words, the population trends, particularly for men, have improved. The rates of smoking in men have really improved over the last 20, 30 years. But for males who are suffering from schizophrenia or depression or bipolar disorder, the rates haven't really changed. So the rate's still appreciably high. Now, not only is the rate of smoking high, which impacts upon their physical health, because these are a vulnerable group who often have a high rate of diabetes, a high rate of obesity, often a high rate of drug or alcohol concerns. So they have multiple physical health comorbidities. Not only is the rate of smoking high, but we seem to do no better, possibly worse, at helping the patients despite them coming into contact with the medical profession. So we need to do a lot more. There's a big incentive to do a lot more. And I believe that the rates of quitting in this population, although they are slightly different to the general population, they're broadly equivalent. In other words, if you have a mental ill health concern, you should be able to stop smoking with adequate help and input if you have the motivation to do so. And that's perhaps the key message. If clinicians and patients can work together, we can start to address this problem. But working on our own, we really are going to be stuck with a major population risk factor, which is disproportionately high in those with mental ill health.
Thank you.